Hi, everyone, and welcome. This is ACC Secondary Care Market event. We're excited to see you today. We've got a good team from ACC here. Looks like people are still joining, so we'll get started as we can. We'll start by opening us up with the ACC karakia. We could flip to that slide. I'll open us here, then we'll do some introductions and we'll get into the main part of the session. Whaia te tika, whaia te pono, whaia te aroha, mo te oranga tangata, kia puke te whaia, ki te o marama, homie huie, tai kie. So, hi everyone, I'm Matt Jones. I'm the head of system monitoring and performance in ACC's commissioning team. I've got my colleagues here with me, which we'll do introductions in just a moment, but I think I wanted to say first, thanks for joining. We've decided to bring a multidisciplinary team of ours together, reflecting what we're hoping you bring to the party as well. So we'll go through today what we see as the opportunities, the problem statements, and where we are as an organization and what we think needs to happen next. This is about the free flow of information and sharing of ideas. So we're really looking for this to be collaborative and engaging, which is why we have the team that we have here. So we'll answer questions as we can. Whatever doesn't get answered in the Q&A, we'll respond back to as well. So we'll bring that back after this session as a follow-up. I'll hand over now to Dilke.
Thanks, Jonesy. Hello, everyone. It is really good to see you and seeing the numbers of people joining increase really rather rapidly. So thank you for giving us some of your time this lunchtime or during this your short break. So I'm Dilke Rasa. I'm Acting Chief Clinical Officer of ACC. I also have a very big interest in clinical quality and safety and clinical governance. I'm Otago trained. My vocational scope is medical administration. I've been at ACC now almost 10 years. I will now hand over to Pete.
Good everyone, my name is Pete Watson. I am currently working on a contract with ACC, providing them with advice on clinical leadership and clinical governance, and we'll talk a little bit more about that, but it's great to be joining with you and the others here today, and I'll hand over to Trudy.
Kia ora koutou, I'm Trudy Scott-Walker. I'm the Manager of Operations Integration here in Health Partnerships in the commissioning team. I'm also the commissioning manager for our moderate complexity or secondary care service grouping. My background is as a pharmacist and also a background in business and hospital management, including in perioperative services. Over to Hamish.
Kia ora koutou katoa, ko Hamish Johnson taku ingoa. I'm a portfolio manager here at ACC. My background's in physiotherapy, but I have been here at ACC for the past 14 years in a number of different roles, but most relating to performance monitoring and management. And the last 3 years, I've been working with the secondary care services alongside Kylie. Over to you. I think we might have just lost Kylie, have we? So I'll hand over to Willa.
Thanks, Hamish. Kia ora koutou. I'm Willa Jones, Portfolio Advisor for Secondary Care Services. I've been at ACC for 4 years, and prior to this role, I've worked in the surgery assessment team. And I'll hand over to David.
Kia ora, David Candy, Health Partner, working and supporting our secondary care portfolios. And physiotherapist by background. And have we got Kylie back? No, in that case, I'll pass back to Jonesy to kick us off.
Perfect. Thanks, David. And for those who don't know, I go by Jonesy because we have too many Matts at ACC. So that's why you might hear Jonesy and Jones or MJ interchanged. At any rate, next slide. Let's jump to it. So today we'll talk about, we'll go through the purpose quickly. We'll then go through what we see as the opportunity and go through Q&A. We'll try to collate those as themes. So if there's, the same kind of question coming in multiple times, we'll answer those as we can. As I said, anything that doesn't get answered will be answered afterwards, and this is being recorded so that this can be shared out broadly. So this can be passed on if we want. Jump to the next slide. Great. So I think we should probably call it an elephant in the room in this space. And so it's probably no surprise to you that a few of us are new to the team, and we're trying to take a new approach at ACC to commissioning, particularly in how we work with providers in the broader health sector like yourselves. We know that last year there were a few things that went probably not the way that we want to do in the future. So there were a few RFIs that went out and some things that were limited consultation with the sector, and that's simply not how we want to do things going forward. The purpose of this session is for us to start having that conversation and open that up. I think we have to be very open that ACC's performance is not going well. That's a matter of public records. You can see that in lots of different areas and documentation, so we've got to do something differently. Our view on how to do that is working with the sector and engaging with people like yourselves on new ideas and finding ways for ACC to drop its overall spend. ACC's overall spend must reduce somewhere. How we do that and where we invest money is really the fun part and the opportunity part of the question that we need to answer. So to do that, we need some help. We'd like your help in understanding what's going on, where you see the opportunities. For us, Trudy will talk a bit more about it, but weekly compensation is a massive lever for us that we'd like to see reduce, because the spend of that, the amount of times we say yes to approving weekly compensation and how long clients stay on weekly compensation are both going up. And what that tells us is we're not getting the outcomes that we need. So we're paying more money to get worse outcomes for clients, which is sort of the worst of both worlds. So what we're here to talk about today, where we see those opportunities in the secondary care market and how you can see that being a sustainable part of the business and the operation that you run. So the ideas hopefully come from you. We've got some as well. We want to work together on that differently than we have before. So if you felt like before things were coming out without notice, we'd like to create a more open dialogue and finding solutions together. Pass to Trudy.
Thanks, Jonesy. So our current rehabilitation rates and weekly compensation costs are not where they should be, and they have been trending in the wrong direction over the last few years, as you can see here. For example, there has been a 30% increase in the rate of injured workers going on to weekly compensation since 2014. And in recent times, the number of clients staying on weekly compensation for more than 365 days has reached an all-time high, with more than 20,000 people being off work for more than a year. This is important to ACC to understand, as it indicates people are not recovering at the same rates they used to, and this puts pressure on scheme sustainability. To the next slide. Firstly, I want to be really clear about what's not the focus of this work. So we won't be talking about FAS, that is bulk funding of the public health acute services. That's not a focus. We won't be talking about non-musculoskeletal conditions. We're going to focus purely on musculoskeletal. And ICP MSK is not going to be a focus here. Many of you will know that ICP MSK was developed to support a subgroup of MSK injured clients of moderate to high complexity. Now, much of the cost of treating these patients actually sits outside of the ICP service in elective surgery, HTI, high-tech imaging, and clinical services. And so there is a crossover, but the ICP MSK pathway in itself is out of the focus of this work. The work we're talking about today has got a broader scope. It's about how all patients access secondary services. And in the main, what we're talking about here is elective services, elective surgery, high-tech imaging, and clinical services, with a view towards how we best integrate these secondary care services with our rehab services and ICP. So, what is the focus? We're concentrating on clients who have had a musculoskeletal injury and who require specialist assessment. These are clients whose needs can't be met in the primary care setting alone. If we think of it as the pathway our clients follow, we're looking at the receipt of referral from primary care, specialist assessment, including diagnostic imaging, interventions, including surgical and non-surgical procedures, for example, image-guided interventions, and post-intervention follow-up. Outcome capture and reporting, enabling self-management and injury prevention, discharge of the client from the pathway, or escalation to other support services. So why have we selected this group as a focus? Well, musculoskeletal injuries account for about 60% of ACC covered injuries, and under our current secondary care services, around 80% of our annual $750 million spend is on clients with musculoskeletal injuries. We also pay $1.66 billion in weekly compensation costs to this cohort each year. Note that our weekly compensation cost here has increased over 70% in only the last 5 years. The average number of weekly compensation days paid has increased by 43%, and the number of clients receiving weekly compensation has increased by 33%. So to summarise all of that, the number of people with musculoskeletal injuries needing secondary care services is growing faster than overall claim growth. More of these people are receiving weekly compensation, and they're receiving it for longer, and it's just putting a significant strain on the scheme. Now, we've been talking a lot about dollars, percents, and growth and things like that, but at the heart of this, we must remember that every accident and every injury impacts a real person out there in the world with livelihoods, with families, relationships, jobs, and it's impacting on their physical and mental well-being. International research has shown that long-time worklessness has been linked to higher rates of all kinds of bad outcomes like anxiety, depression, suicide, hypertension, diabetes, stroke, and early death. There's clear evidence that the longer a person is away from work, the less likely it is that they will ever return, and the more likely it is that they will lose their job. It just shows how important it is that we're getting people back to work as soon as they're ready. We're under no illusion that the challenges we face are being experienced by other funders of healthcare in New Zealand and other jurisdictions around the world. Our single biggest opportunity to ensure sustainability of the scheme is to improve rehabilitation outcomes and get our clients and our patients back to work. It's better for us, it's better for our providers, and it's better for New Zealanders. Next slide, thank you. We do recognise that our current contract structure doesn't support our clients' recovery pathway. It breaks it up into silos, and then our processes can get in the way of delivering timely care. This all means that we lose sight and accountability of client recovery goals and outcomes. We've identified 5 key areas that would help to enhance recovery outcomes and ensure sustainability. The first is that we manage referrals from primary care. Secondly, we make fair and timely cover and entitlement decisions. Thirdly, we need to be very considerate of clinical safety and quality. Number 4, we need to support productivity and efficiency. And number 5, we need to capture, report, and improve client outcomes. So the team are going to describe each of these in a little bit more detail, so I will hand over to Hamish.
Thanks, Trudy. Just before I delve into referrals, if you do have a question or comment, please use the Q&A function at the top of your screen. And don't worry if it disappears, the team will pick those up in the background and theme them up together for the Q&A session. Thank you. So referrals. The referral from primary care starts a client's access to secondary care services. Now, we've heard that quality of referrals is mixed and that patients are referred based on relationships, and patients are sometimes referred when they don't need specialist assessment. And there's no visibility of capacity, so where is the next available person in the system? So we're really keen for your ideas on how can we support patients to be assessed by the most appropriate specialist and at the right time? And also, how do we make sure the right information is available for the referral to be triaged, prioritised, and to support the assessment? So just an example of this is that conversion rate from surgery after an orthopaedic assessment is around about 20%. So I guess there's a question is, could some of those referrals be sent to other specialists to make sure that we're maximising the availability of orthopaedic assessment for those who need it? Now, cover and making entitlement decisions is absolutely ACC's role and responsibility. So most musculoskeletal injured clients, they have real easy access into the scheme, and this is a good thing. So the vast majority of clients are able to access their, on average, 1 GP visit or a couple of physio treatments they need to quickly resolve their presentation. But there is a missed opportunity to consistently relook at cover following specialist assessment. And that is the key point where we can get a confirmed diagnosis, with or without HDI if required, and access to that specialist clinical reasoning on how that presenting injury was caused by the accident. And of course, it sends someone onto the recommended treatment path. So we've heard that claims are lodged with injuries that providers know will get through the system quickly rather than the actual diagnosis. We've heard that delays in our decision-making can hinder client rehab outcomes. And we've also heard your frustration about information is provided to ACC, but we don't use it to make decisions. So while we're looking at this issue, we are also interested in your views on how and when we could receive information so we can make fair and timely cover and entitlement decisions, and how we can use that information early on and avoid those frustrating medical case reviews later down the track. So just an example of this, we spend approximately 8 million on ultrasound guided injections for conditions that ACC can't cover under our current scheme settings. I'll now hand over to Pete, who will talk about clinical safety and quality.
Thanks, Hamish. Look, so I just really want to sort of loop back to what Trudy was saying and reiterate how important it is that we think about patients and patient journeys, not just about cost claims and entitlements, and the importance that poor recovery and poor rehabilitation has on individual outcomes, psychologically as well as physically, on whānau and relationships and wider society. So, really key that we do that. And again, to think about this in terms of quality, that when you have a system that is fragmented, and when we look across performance, we see how variable our treatment and rehab is, it's no wonder that we've got concerns about quality and safety. Now, the answer to working with quality and safety is not for a bureaucratic central agency to determine what to do, but to work with you who are delivering that care, and to work with consumers and people who are receiving the care. And so that's how we're trying to really reorient the system here. We want to work with you to be able to answer the questions about how we ensure that the services we deliver are equitable and are safe, that they're effective and they're evidence-based. We need to work with you on how to redesign the system, redesign a system that works to maximize outcomes, promote treatment and rehab that works for individual patients and consumers. We've been thinking about ways in which we do that, and I just wanted to really reflect on a couple of those. And the first was the use of data and how we do that. We have data. It's not always the best data or the right data, but we have a lot of data, and how we can use that in a transparent, safe way so we can focus on quality improvement in terms of our system. But we also want to focus on clinical leadership. So that's about how do we strengthen the use of clinical leaders across the system to help drive the system forward. And finally, of course, we need to ensure that we continue to have consumers at the centre of what we do and providing feedback. So I'll leave it there, and I'm handing over, I think, back to Kylie if she's now joined.
Yeah, thanks, Pete. Hopefully everybody can hear and see me. Kia ora koutou. I'm Kylie Brown, Portfolio Manager for Secondary Care Services. I'm going to talk a little bit about the opportunities that we have to boost system productivity and efficiency. Now, we've heard that we aren't making the best use of in-rooms, hospital and day-stay procedures. We've heard that new technology is available that can improve efficiency, but we've been hesitant to adopt it due to concerns around cost. We've been told that theatre lists are being set in agreement between surgeons and hospitals, with surgical lists being prioritised by who the funder is. Now, we've seen a decline in the timeliness for high priority surgeries. It now takes around 42 days from ACC's approval to perform high priority surgery, and that's compared to 31 days back in 2020. So this means that our clients who have clinically urgent needs, or are receiving weekly compensation, or relying on high-cost social rehabilitation services, they're waiting longer for surgery, and this is adding more cost to the scheme as they wait. Routine surgeries are now taking around 71 days, which is compared to 62 back in 2020. So these are the areas that we're interested in opportunities to improve. How can we create a system that encourages the productive and efficient use of our workforce, our theatre space and infrastructure? And how can we support new technology that improves outcomes for clients and adds value for providers and ACC? And how can we make better use of theatre time and space to ensure that the clients are accessing surgery that's timely for them? We also have the opportunity to improve client outcomes and the collective responsibility for other outcomes. Sorry. We've heard that there are many factors that influence outcomes. It's a hot topic. Everyone's trying to capture different outcomes in different ways. We've also heard that our decision-making can sometimes hinder clients from achieving good outcomes, and that outcomes are influenced by services delivered by different suppliers under different contracts. Now, we've seen this when we've looked at average post-surgery return to work timeframes. We have significant variation between surgeons. Cuff repairs of the shoulder, for example. For sedentary workers aged 45 to 55, we see a variation of almost 150 days. And so what this means is for the same client cohort, we have surgeons averaging a 50-day post-surgery return to work and surgeons who average almost 200 days. So clients undergoing similar procedures are receiving very different outcomes. We have started sharing return to work data with our suppliers and providers and looking for opportunities to support improvement. How can we better understand the outcomes that our clients achieve? Tools like patient-reported outcome measures, patient-reported experience measures, as well as for recovery and return to work. How can we reduce the variation in outcomes that our clients are receiving? And how can we ensure equitable outcomes for everyone? I'm going to pass over to Trudy to take us through some details of how you can contribute your ideas.
Thank you, Kylie. We need your input. We would really like to hear from you with any and all ideas to improve recovery outcomes, to get people better and back to work more effectively and efficiently, and to help ensure sustainability of services for clients with musculoskeletal injuries well into the future. Please share your ideas, both big and small. We want to hear ideas that could be implemented quickly, for example, within a year, but we also want to explore any big ideas you have, including how we could change or transform the delivery model of these services. You can provide your ideas by completing a request for information, an RFI, on GETS. The information is here, and Willa will talk you through more information around how to do that. We've kept the RFI super simple and high level. We are not looking for really detailed cost-benefit analysis or highly detailed plans. We just want to hear how you think we could work differently in ways that will positively impact your patients' recovery outcomes. And over to Willa.
Thanks, Trudy. So we want to make it as easy as possible for you to get your brilliant ideas to us. This is why we will be using GETS. GETS is the Government Electronic Tenders Service portal, an online system that government organisations use to promote opportunities to work with us. We'll send everyone registered for this event direct links to the GETS and the recording. This is expected to be out by Monday or Tuesday next week, and then you'll have around 4 weeks to submit ideas. All questions relating to the request for information must be raised through GETS. This is to ensure this is a fair and transparent process. On the screen here, you'll see some indicative timeframes if you need to refer back to them once we share the slides with you. Once submissions have closed, we'll spend some time reviewing the ideas. Around the end of April or early May, we'll update you on the next steps and any confirmed outcomes. This is likely to be via provider update and possibly another online engagement. If it is an online engagement, we'll let you know in advance. We have a dedicated webpage on acc.co.nz that holds all the information on the health sector engagements. This page is called Working Together to Improve Patient Outcomes and is under the Provider News and Events section. This will include GETS details shortly. Our monthly provider update newsletter will also be a good source of information. We will provide regular updates through this, and if you're not already receiving this newsletter, please go to acc.co.nz, search for Provider Update, and click on the subscription link. As a final reminder, all questions need to be raised through Gets, and we will answer them there too. I'll now hand over to David to take us through some of the questions we've received.
Thanks, Willa. Right, so first question here is, to improve patient choice, support decision-making and improve transparency, why doesn't ACC work with the sector to publish surgical provider outcome data as is done in other jurisdictions? I'll pass that one over to Hamish.
Yeah, thanks, David. And yes, great question. And I think both Pete and Kylie touched on this, that we are making steps towards making that information more available at a start, making it available for our providers. But it's a really good point around data transparency, and that's, you know, ACC making our data available for providers to inform their services, but also providers making their data available for patients to make informed choices about where they receive their treatment. Look, we don't think this is just about surgeon outcomes either. This is, you know, about all scopes of practice, but probably more importantly about the pathway that clients are on, and really understanding those outcomes and making that available for them to make informed choices.
Can I just, it's Pete here. Can I just further add to that, David? And that's just to say, from my perspective, I think the data is most importantly used by providers to be able to compare and look at how they're going compared to others. There's lots of reasons often why data is different. There's lots of factors which can drive difference, and we need to understand the reason for the variation. There's that idea that, you know, there's warranted and unwarranted variation, but the data will help us have those conversations. So the transparency is super important for us to improve, and you know, is taking a good hard look at it itself about how it can make that data available to help us all improve the system collectively. So a big piece of work, and pretty exciting, I think, and the opportunity to have some really good conversations to help take us forward.
I think just to further, further build, Pete, it's part of our strategy going forward. So something about the new SC&P view is data sharing. So I think if I look backwards at what ACC's done over years prior, I think we haven't been great about putting our story out there. What we see is good and bad. Like Pete said, there's probably explanations for all of it. Maybe some of it is actually right and justified, but we want to do that and be more clear about what we think good looks like, what we think better looks like, and how we improve. We think data sharing is a key component of that for our future and how we'll approach our strategy going forward. So expect a lot more of that. Great question.
Thank you. How can contracted service providers be empowered to be working collectively to the client's rehabilitation objectives in a way that doesn't require them to retell their story to each service provider? Hamish.
Yeah, definitely acknowledge that our current contracts for secondary care services break up the client's pathway, and that can be a barrier to information sharing because it's between different entities or different providers. This has certainly been something that Integrated Care Pathways has looked to resolve, where there's responsibility for a larger part of that client's pathway. But we definitely believe that integration of services could be a way to reduce patients moving around from service to service and having to retell their story. So very much keen to hear your ideas about how we could do that better.
Thank you. Next one, what is ACC doing to aid reducing wait times for specialist appointments, particularly in Tauranga? Wait times are delaying Kirataki recovery times and return to work. Kylie, want to take that one?
Thanks, David. Yeah, this is an issue, and currently we have very limited visibility regarding the capacity that's in the system. The point that the referrals made to the specialist isn't something that is visible to ACC, which makes capturing wait times quite difficult. And I think Hamish touched on this earlier in the presentation, that more work needs to be done on developing some standards for triaging referrals. We do understand that not all clients need to be referred to see a surgeon. And I think focusing on this triage should help reduce some of that pressure and increase some of that capacity for specialist referrals, ensuring that our clients are receiving the right treatment at the right time. But again, this is definitely an area that we're keen to hear your thoughts and ideas on how we can work together to improve this.
Thanks, Kylie. Would you consider a specialist registrar contract for registrars who are part of a specialist training program? Hamish.
So probably not a specific registrar contract, but definitely acknowledge that workforce training is super important to be able to increase the capacity and to be able to deliver quality care. ACC does have some legislative restrictions about what can be funded, but certainly eager to explore models of care that facilitates workforce training and upskilling and making sure people are working at the top of their scope. So yeah, definitely welcome suggestions on how these models could be integrated into our into new delivery models.
David, if I can just jump in there too. So I guess one of the area, I mean, ACC's relationship with Health New Zealand's not all about the FAS. And I know we said we were not going to talk about that acute funding. There are a number of other areas, and workforce is one of them, right? And I know from the this sort of discussions which have gone on, it's how do we work across the system on our workforce issues. Now, it'd be great if somebody had an overarching workforce plan and strategy. We don't have that despite multiple attempts, but I think what we are signalling is we understand some of the constraints that the workforce has in terms of our delivery, and we're starting conversations and new conversations about that. Hopefully they will build on what's happened before and we'll come up with some new approaches that will be helpful, but keen to look at those.
Thanks, Peter. What does ACC believe the role of advanced practice and specialist physiotherapy can play in developing a more sustainable model of care where access and costings can be considered? Kylie, I'll give you first crack here.
Thanks, David. Yeah, physiotherapy specialists, they play an important role in supporting clients through non-surgical treatment pathways. I think this ties back to sort of the question I answered before as well. There are examples of models where physiotherapists are being used to triage patient referrals, and these triage models do ensure that only patients that need specialist referrals are receiving them, and also promote non-surgical treatment options. But again, we're keen to hear from you regarding how specialist physiotherapists can work with ACC to enhance those recovery outcomes.
Kylie, I might just add a bit here as well. So I'm kind of building on some of the things Pete said earlier about ACC seeing itself and its role within the health sector. I think we're even more focused on that than potentially in the past. And so part of that is this keeping close to what is happening across various disciplines and scopes of practice, seeing what those changes might look like compared to current state, what they could mean for ACC, try and horizon scan and really become more integrated into the overall health system.
Thanks, Dilke. What do you see as the role of community-based musculoskeletal medicine specialists in community-based musculoskeletal injury program? Hamish.
Thanks, David. Yeah, look, musculoskeletal medicine specialists, like what Kylie just said about physio specialists, obviously there's an important role in supporting clients through non-surgical pathways. We probably do want to signal a shift away from talking about individual vocational scopes to more pathways of care, and how they're delivered and how those teams work together to best support patients. I think that's the real real opportunity is looking at what should those pathways look like, and then who is best able to deliver them.
Thanks, Hamish. You mentioned increasing weekly compensation payouts. Over the last 5 years, there's been changes in the socioeconomic environment, i.e. higher income due to inflation, cost of living and work opportunities. I wonder whether this has impacted on the claims rather than problems with service provision. Is it an issue of higher cost rather than poor recovery? And do we have a breakdown of claims, cost per claim, and cost of individual compensation, etc.? Go to Trudy.
Thanks, Dave. We do have more data, not to hand right now. We can try and put some of that in the Q&A that we publish. There is definitely a role that inflation and increased wages and things like that is playing, but that's certainly not all of it, because we know people are spending longer on weekly compensation than they were before, which is an output of people taking longer to get better. So people with the same sorts of injuries are taking a longer period to get back to work. So that's probably the main clue that there is something else going on here. It is about recovery. We know that weekly comp certs or off work certs are being written for longer periods, and we're also seeing an increasing proportion of fully unfit certificates versus fit for selected work. So there's definitely some patterns going on out there that aren't related to those economic factors, but absolutely acknowledge that that is part of the story.
Yeah, I think just important to say and add, Trudy, it's definitely part of the story, not the contributor. The contributor is more people on weekly comp for longer, and we're seeing that across a range of services, particularly in the secondary care market. What we've heard from providers we've spoken to thus far is it's a bit of a connectivity issue, and it's about how we talk as groups and multidisciplinary teams across recovery journeys and pathways. So love to hear the questions about pathways and thinking about things a bit differently, because that's where we think the magic is. But hopefully you've got those ideas as well, and that's what we'd like to hear.
Thank you. Next one, the time taken for ACC to respond to correspondence is a clear opportunity for improvement. For example, it appears ACC will no longer cover imaging for an adjacent body site. As far as I'm aware, this change was not communicated to providers. For example, this could be a patient who has an initial claim for a shoulder injury, who's then diagnosed with radicular pain. The client now needs an application for an additional diagnosis, which may take another 20 days at best. Hamish.
Do you want me to jump in and take this, Hamish?
Sure, Kylie. Sounds like the answer's on your tip of your tongue.
Yeah, so this has been an issue. I will acknowledge this has been an issue that's popped up in the last few months, and I think we have been dealing with our high-tech imaging suppliers on. I think we have acknowledged that some of the wrong advice had been given to our provider helpline teams, but I can confirm that adjacent body sites just require that phone call through to our provider helpline to double check the cover, and then they can proceed. They don't need a written application for prior approval.
And I guess further to that, Kylie, they don't need to request additional cover either prior to proceeding to the imaging?
Not prior to proceeding to the imaging, but obviously if the imaging shows something that is an injury caused by that accident, then an application for cover should be made by the provider that's responsible for that client's care.
David, it's Pete here. Can I just jump in a minute? And look, similar to when we held this market event in primary care, there are a number of things that were brought up that we need to focus on internally for the current system and how the business is currently done, and that's around communication and some tweaks that can be made to improve the system, and absolutely they should be the focus of some of our energy. At the same time, what we're trying to do with the market event is to think about the new things and the new approaches, the innovative, different ways we can start to tackle the problems that are in front of us. And I think it's trying to get that balance. So absolutely suggestions that we can improve the system currently as it stands. Let's have a look at those, but also please let's also put on your real creativity, innovative. There's no dumb ideas out there. We want to hear them all, small and big, about how we can, really shift the dial on what we do, because, there's a sort of feeling that no matter how much we tweak, we can't really make major shifts unless we have some real creativity and new thinking. And we think you're the people out there in the system who are delivering the care where that is, not here sitting in, the office at ACC. So I guess that's the opportunity here for everybody. It's a genuine opportunity. We really want to focus on, how we can do the business better, but also what we can do differently or new. So just wanted to put that in there. Good on.
Thank you. How can we support the standardization of outcomes data using validated tools? Kylie or Willa?
I was going to suggest Hamish take that one.
Oh.
Do you want me to make a start? And then you can...
Yeah, thanks, Dilky.
So we're absolutely I've just come off of a session actually related to trauma, where we've talked about some outcome data and the importance of it. So what ACC absolutely wants to do is grow our maturity and our thinking around integrating outcomes data, patient outcome experience, obviously what's seen clinically as well. And that is definitely something we want to do. It's something that we appreciate we need to achieve consistency over and, take a more strategic approach over. So absolutely, any ideas in that area as well, slightly off center in terms of the exact pitch of this presentation in terms of the responses we're looking for, but definitely after any suggestions in that area as well. I'll hand over to anyone else who wants to add.
I'd just add, Kylie talked about this earlier, we acknowledge that lots of different funders are asking for this as well, and where appropriate, we should be lining up so we're not replicating different systems and just creating churn in the system.
Thanks, Hamish. Do we have data on equitable outcomes that can be shared? What priority is there for Māori Pacifica in this work? Dilky.
Now, I don't know if we've got data that we can particularly share. I'm going to leave someone else to talk about that, but that is absolutely part of the focus as well, right? Access, experience, and outcomes for those who aren't achieving that or having that experience with ACC currently in the same way as others is absolutely a priority. So let me just say that. And on the data question, I don't know if there's anything right now.
I think Dilky, that's something we need to improve. Obviously, we've already talked about improving our data and that being part of our strategy. We've got some services, some newer services. I'll mention ICP, where we've got a much better lot of data going both ways, and we understand what we're delivering in terms of equity and outcomes there with the small cohort of patients who have completed service in that within that service, but I haven't seen that same level of data for any other service at this stage. So that's something we'll be looking to improve, and it is a priority.
And I guess that speaks to the transparency point I think Jonesy and others made, right? It's transparency of data both ways, us asking that of you, but equally us sharing back, and that they're all part of that continuous improvement approach.
Thanks, Dilky. Has ACC considered the delays within its own system that's contributing to longer periods of weekly comp? Trudy or Matt?
I think
Pete, take that one.
I think Pete really. Oh, sorry. I think Pete really responded quite well to that earlier. In terms of, yes, we know that there are issues. We know where they are, and we are working on them. Pete's got his hand up. I think you said it more eloquently earlier, Pete.
I think there's absolutely no doubt what they do. And so that's why we continuously are trying to improve internally the processes. And yeah, it is a real problem in terms of how we have the system set up. And so opportunities to work and essentially to devolve more accountabilities out into the system are also what we'd like to hear from you about, because we think that people out there, rather than internally within ACC, would be way more efficient at managing much more. Now we've done a lot of that, but there's more opportunity. I think the other opportunity, and there's a number of questions, David, that I think have come through, and I'll just pick them up, which are talking about the links between primary and secondary care. And we've held this market event for primary care, and now this is secondary care. But for both, obviously, again, it's part of a system, right? And for a patient journey across that system, there will be bits where the ideas need to be connected up. So please also think about what you might suggest in terms of how we integrate primary and secondary care across the system for a patient journey. It's important they're not, again, two discrete silos. We have, for the sake of trying to think about groups of areas that we're focusing on, put them in these two groups, but obviously they are connected and interrelated. So where you have thoughts about how we might do that differently, such as medical certification, please feel free to also offer up suggestions around that, or anything else where you think, although it might be in the primary care bucket, if you like, you have some great ideas about that as well.
The only thing I'd add is, I think for us, it's about the specificity here. So where are the specific points that you see areas for improvement? Like Pete and Trudy said, broadly, we're always working on continuous improvement. It's a big machine and that can be a bit slow. So if there's something you see specifically in your patch that you think can be fixed and contribute to this, we're very open to that and making those kinds of changes. Like Pete said, we've done that in places like ICP with more trusted provider frameworks. We're open to more of that, but we need to be pretty clear about where that is.
Thank you. Look, I think we are approaching the end of the allotted time here. I think quite a few of the questions now that are coming in are fairly similar. Any we haven't got to now, we will look to address with a written response as well. So with that, I'll hand back to Matt Jones.
Great. Thanks so much. Thanks everyone for joining. Really appreciate your time. And as I said, this is the beginning of what we think a different way of approaching these kinds of problems together, us talking about what we need to do as ACC and how we create a more sustainable sector. So thank you for your time. Thank you for your ideas. We generally will take them under advisement. We will come back to you with things after the process. So really look forward to what hopefully turned out to be some pretty radical and different ideas on models of care and driving improvement. So we'd love to see that be bold, and let's see what we can do together. I'll close us with karakia. Whaia te tika, whaia te pono, whaia te oroha, mo te orangatamata, kia puta ki te whaio, ki te o marama, homie, huie, tai kie. Thanks again, everyone. Bye-bye.